So welcome to the Center for Global Development. I'm really happy to see a number of familiar faces in the audience. We had more than 300 people say they would join online, so hopefully that is also the case. We're pleased to have you join too. I'm Amanda Glassman. I'm the Executive Vice President here at the Center for Global Development, and I also work on global health policy and finance. We're really pleased to host everyone today to talk about one of the most difficult but most important issues in global and domestic healthcare, and that is how we set priorities for scarce public and aid spending, or who gets what when, at what level, and for how long. The problem of priority setting is absolutely universal in countries at all levels of income because, as every article ever written about this topic says, demand for healthcare is potentially unlimited, and our resources are necessarily scarce. How limited are they? Well, in low-income country, governments are spending about $270 per person per year versus something like $10,000 per person per year in the United States. But if you've been to the doctor lately, you know that $10,000 doesn't buy you a huge amount of health care. So there are choices to be made. Now, the amount of spending grows alongside economic growth, but it's still well short of the requirements that were estimated by the Global Health 2035 Commission, of which Dean Jamieson led with colleagues. And although aid is still significant in some countries, we've reached somewhat of a plateau. And a key related question is, well, what are we trying to achieve with that scarce public spending in health? Is it actually health, or is it more fairness, more equity, greater financial protection, less suffering, or maybe all of this and more? And so how do we consider those multiple objectives? And that's what this book that we'll discuss today is all about. These decisions are consequential. I think that the moral philosopher Toby Ord has put it best. Of the thousands of medical interventions that have been evaluated for their costs and their effectiveness as part of the Disease Control Priorities Project, the best intervention, the one that has the most benefit for the amount of money that we spend, say condoms to prevent HIV, are about 25,000 times better in terms of the health that they produce than the worst intervention, say treating Kaposi's sarcoma. So make no mistake, the worst intervention still produces benefits for the individuals that receive that care, but if you spend on the worst to the exclusion of the best, we forgo an enormous amount of health. So we're proud to host the editors of this book who are truly, I don't know, I've like my whole career, I've been watching them. I'd say we'll start with the two professor practitioners who have led this effort, Ole Norheim and Ezekiel Emanuel. You have their bios for all the details. But I would say that in addition to his academic work on fair distribution of healthcare, Ole Norheim has led Norway's National Committee on Priority Setting in Healthcare, and that means he understands both the technical issues as well as the political issues, which are enormously important. And then Ezekiel Emanuel has stood for ethical integrity and rationality in health spending in the United States, but has also been a longtime ally to those of us who are working in developing countries and with aid agencies. Both are pairing the highest scholastic rigor with really accessible work that enables us to work in the real world, and both understand the really hard politics of priority setting. So it's an honor to host you. So first, I'll turn it over to Ole Norheim. Thanks.
Thank you very much, Amanda, for this nice introduction, and thank you to the Center for Global Development for hosting this book launch. So I'll jump right into some, see if my slides will turn up. So I'll just explain the framework that we organized the book around and give an example of some pressing priority setting problems in a country I know very well, Ethiopia, and try to summarize the book compared to real world priority setting. I'll try to do it in 10 minutes. So when we organized the book, we thought about the kind of principles and information needs and concerns we have when countries set priorities. And cost effectiveness have been a key criterion, and rightly so. But we also wanted to emphasize that we need to look at more than health benefits. So we are interested in non-health benefits, such as financial risk protection, reduction of poverty, but also other benefits like better schooling, productivity, other benefits. So these are important extensions of cost-effectiveness analysis that we discuss in the book. Also, distributional impact equity. It's well known that cost-effectiveness give you average results, but how are these results when we disaggregate them into groups that or individuals that we care about? And then, of course, distributed fairly, and that this has to be organized within ideas of so the methods going beyond cost effectiveness doesn't mean that we will exclude cost effectiveness, but we have looked at extended cost effectiveness analysis, moving towards benefit cost analysis to compare health with other sectors, social welfare functions to capture processes like institutionalizing health technology assessment, other ways of making the therapy setting process more open and transparent. Okay, I'll try to do this. So this is the framework. How does it look at on the ground? So as part of DCP, I've led with Stefan Vergé the Disease Control Priorities Project for Ethiopia, where we have trained people and given technical support together with WHO on the revision of the package. And the essential package that was comprehensive was launched by the Minister of Health in November 2019. And we made a roadmap for the revision process with identifying relevant health services. So we consulted a lot of experts, people working on the ground, and they came up with a list with more than 1,500 interventions, a wish list. And then we discussed, or they discussed, this was owned by the ministry and organized by the ministry, had consultations with health experts, people from the different level of the health system, and patient organizations deciding on the criteria. And they emphasized burden of disease, cost effectiveness, equity, financial risk protection, and budget impact. All this was put together with the help of WHO and their tools, and using information from DCP3 and the Tufts Cost Effectiveness Registry, and was used to rank services and then adjusting for equity impact and financial risk protection by investing in these services. A new round of consultations on the final package, and then now they are costing the package to see whether that would be affordable or not, or how to adjust it. So these are the criteria they decided on, also public acceptability, and they added political acceptability. So that's also very interesting. This was owned by the Ethiopian ministry, and of course they have to base their decisions on their own values and concerns. So just to give you a glimpse, so what they did, ranking all the interventions by cost effectiveness, since WHO was involved, it was ACERS and not ICERS, for those of you who know that. Very complicated. We also scored for equity and financial risk protection, getting expert input through a Delphi process. I just give you a few examples of how the list looked like. They ended up with a list of 1,000 interventions, and this is one on RM and HCH. So they divided services into high, medium, and low priority. And as you can see here on family planning, most of them are ranked as high priority, although sterilization services of medium priority. On cervical cancer, so they're expanding now into more and more NCD services for cervical cancer treatment, stage 1, high priority, stage 2, medium priority. For colorectal cancer, I don't know if you see it below here, all of them were judged to be of low priority. So very much in accordance with DCP3 recommendations, prevention, early detection, and early treatment would be given high priority. Remember that Ethiopia now spends $32 per capita, so they can't really expand a lot before they get more funding for the health services. On cardiovascular disease, treatment of myocardial infarction with PCI, low priority, no surprise. Treatment for acute suspected bacterial pharyngitis, preventing rheumatic fever, that they have a lot of actually, is giving a high priority. So this just gives you a flavor of the level of detail of the ranking list, and actually quite tough choices being made, but made on evidence and consultations. Just to summarize then, so there was around 60% of high priority services among those 1,000, 20% medium priority, and 20% low priority. And it was allocated to delivery platforms. So the green ones are primary care. That includes health posts, health centers, and first level district hospitals. And you see most of the services are delivered at primary care level, around 20% at general hospital level, and about 20% at tertiary or referral hospitals. And the high priority services are meant to be delivered without any co-payment, medium priority with some co-payment, and low priority with full cost recovery. So that's the financing mechanism they have built on, that they have had for more than 15, 20 years. So summing up, what we see is that it was important to have this process led by the country, but of course, and that the principles that DCP builds on and that we discuss in the book are widely shared, but also local values influence both the process. It's not as inclusive as we would, or as one of the book chapters recommend, and the principles might have been balanced and weighed in different ways, but I think that's appropriate that the country decide on how to make those decisions. What we learned is that we don't have all this evidence, so even with the best evidence available, we had a lot of gaps where you couldn't really point to the cost and impact, so we needed a lot of additional expert judgments. So it's very data and evidence hungry. And we couldn't really build on a lot of the methods that we discuss and recommend in the book. We built on cost effectiveness analysis. That's where we have the evidence, that's where the studies are. So there's really a need, I would say, for more development of extended cost effectiveness analysis, for more services, and the same more cost benefit analysis. We used a few of those results. And working on financial risk protection and equity needs a lot more of methods development. So I think the book is needed, but it's just the start of further methods development and further thinking about priority setting. Thank you.
Now I have three different ways of speaking to you. First of all, I want to thank everyone for coming for this book launch. But let me begin my interest and co-conspiratorial collaboration with Ole to get this project off the ground many, many years ago was founded on the fact that I was working in the Obama administration, and we had a global health aid budget distributed in many different ways, as those of you who know it. And I was very frustrated by how haphazard it seemed that our funding priorities were. And I thought that we really needed to get a better way of thinking about what we were funding and what would that way be. There was a lot of pushback about simple cost effectiveness analysis for a reason. We've launched this project, these many years ago. I don't know about, depending on how you count, something like 7 years ago, multiple meetings, lots of arguments, and coming together finally in this book, which has 18 chapters that covers the the problem from various different perspectives, the funders problem, the governments of low middle-income countries and others, looks at systematic ways to make allocation decisions, what public involvement should be, some unanswered questions. So I'm here to really, I'm going to give you a flavor for some of the areas of consensus that we came to, some of the residual, very, very important areas that we couldn't come to consensus with, where there was still residual disagreement, and as Ole mentioned, areas that we think need substantial more brain power and discussion. So let me begin first with what may seem obvious to this room, but is hardly uniform and universal, which is that we need a transparent system and method for setting priorities, both in a country and for funders. Lots of these priorities, at least certainly as I experience and as we can see in many countries, very haphazard, very opaque. Decisions are made that don't seem to be easily justifiable, and certainly sometimes never justified in public to the people who are going to experience those allocations of resources, the services availability, and the cost. Second, we did think that incorporating cost effectiveness was absolutely essential. It is a decision-making process. It does give us an insight into what the opportunity costs are of funding one program versus another. We know that a lot of countries use it for especially for drug coverage, but not only for drug coverage in developed countries, and we think it's a good basis on which to start. But as Ole mentioned, there is a very strong view that we needed to go beyond cost effectiveness and to go into extended cost effectiveness for at least 2 reasons. First, there's an important need to integrate things like financial risk protection, not just the health benefits that you're going to get, but the financial risk protection. How many people are you going to save from falling into poverty? You know, in the United States, we have the concern, how many people are not going to go bankrupt by how we allocate our resources in healthcare, how we adjust what we cover with what co-pays. Similarly, we thought that it shouldn't be just financial risk protection that needs to be included in extended cost effectiveness, but we also need to include equity concerns in that area and making sure that various groups are considered, whether rural populations compared to urban populations, women compared to men, et cetera. And that this extended cost effectiveness in a very robust fashion we thought was a big advance over cost effectiveness analysis. Now, even if you do extended cost effectiveness analysis, I think one of the ongoing criticisms is, you know, somehow it's anti-democratic. It's very technocratic. It simply crank out the numbers and then tells you what to do. And one of the things that becomes obvious once you think about it, and especially once you go to extended cost effectiveness analysis, is that there is a vital, inescapable role for public engagement and public setting of priorities. When you get your book, and I urge you all to buy a copy, it'll go to my scholarship. No. Page 97, I recommend you just peruse page 97. There's a 2x2, but there's also a very relevant graph, which I think is very, very helpful. And I'll just tell you that graph has on the x-axis, imagine it, deaths averted, so you get sort of the health benefit in terms of death averted. And on the y-axis, number of poverty cases averted, so you get the sort of financial risk protection. And what you see is that there are, and it plots out, I think, 9 or 10 different interventions, everything from rotavirus vaccine to cesarean section to hypertension treatment. And what you see is that some interventions don't save that many lives, but really prevent people from falling into poverty. Other interventions save lots of lives, like the measles vaccine, don't avert that many people falling into poverty. Now, when you have those kind of trade-offs, an intervention that actually saves lots of people but doesn't avert poverty versus interventions that averts poverty but may save only a modest number of lives, you have a trade-off that is fundamental that requires a balancing of values as to where you're going to allocate your resources, assuming you can't say, we're going to take it all, which we can never say. And that, as we agreed over our deliberations over years, is absolutely fundamentally requires public engagement to wrestle with and to come to a resolution on. It's easy to say we'll go for prevention versus complex treatment, but even in the prevention side, we realize that some things aren't cost effective, but some things will prevent poverty more than others. The fifth sort of consensus point I want to emphasize is we wanted people to think more broadly than we usually do, certainly MDs like me usually do, right? We think of, let's think about health interventions, vaccines, cesarean sections, drugs. But we recognize in this that it's very important to consider non-health interventions that can have much bigger impacts on health and also on financial risk protection, whether they're education, nutrition, housing, or other elements. Ironically, over the last 2 years, the American healthcare system has sort of got religion on this. We put it under the rubric of social determinants of health. We now need to address them. Every health system in the country is addressing them. Every payer is thinking about them. But we think they're very important. And in low and middle income countries, they're often things like, better roads to reduce traffic accidents, taxes to discourage whether it's sodas or excessive alcohol consumption or smoking. But we thought it essential not to be narrowly focused on health interventions, but to go beyond it. And the last consensus recommendation, we have this in a paper which is in the actual last chapter, is the importance of including stillbirths. There is a very interesting factor that many of you will know better than I. When a baby is born, we start counting them and we start thinking about interventions for them. But stillbirths from 28 weeks on, also very important. No reason they should not, interventions for them and to promote healthy lives among them should not be considered. There's very good rationale, which we go into, to consider them. This was brought home to me. I was in Ethiopia in a small second-tier hospital in a very small town. They brought us to the back of the what they called the NICU, and there were 2 babies. There were 5 babies there that I want to mention. One was 28 weeks, no respirator, doing fine. I was like, wow, you can do this in rural Ethiopia, and you don't need all that high-tech stuff of the Mass General. But there were also triplets there who had been born at 35 weeks, each about 1,500 grams, that were actually doing well, again, all on their own. And so thinking about preterm births and not just starting the clock at birth seems to us important. I just want to highlight in my closing few minutes 2 fundamental unresolved issues that we had lots of drag-out fights on, but fundamentally no consensus, and people fell on either side. The first was whether to use discount rates or not when discussing healthcare services. Fundamentally important, we know that in most cost-effectiveness analysis, we use a discount rate. The future is not as valuable as the present. There's a very big disagreement in the group about whether these ought to apply to healthcare, whether healthy life today versus a healthy year tomorrow, or in a few years, we ought to discount the few years from now. The second one, which is very close to my own heart, is the question of whether and how much we ought to have age weighting involved in the priority setting. Should we give priority to younger children, or should it be uniform across the age span? And frankly, we, again, had disagreement, lots of discussion, but no final resolution. I think the book, as I've tried to suggest, is rich in the issues it tackles. We don't shy away from controversial topics. We try to come to a consensus whenever we can, but we also recognize that there are areas where we're not going to come to consensus despite years of deliberation and I think very, very frank discussions. Obviously, this is only the tip of the iceberg that I can go through, but I think you will find this a very thought-provoking book, and one which we hope, as Ole mentions, advances the field, recognizing full well, as I've just discussed, there are unresolved fundamental issues, recognizing full well we're not at some final state, but we have to keep working. On the other hand, if we do, we think, adopt the recommendations in the book, we think we can make a serious advance in our thinking, but most importantly, a serious advance in how health and well-being is distributed across the globe and improve the value we're getting for the dollars that we're spending. Thank you. And I think next we're going to our panel.
Go ahead. Thank you. Okay, thanks very much, Ole and Zeke. So, all right, I'm first going to just ask each of our panelists to give their 3 to 4 minute reaction to the book as you've read it, what you see as well. And we have 2 editors and 2 independent commentators who are experts in their own right on the issues and ethics of priority setting. So maybe we'll start with the 2 insiders, and then we'll turn to those of you who will give us a more independent view. So Joe, you're one of the co-editors. You're obviously a bioethicist that has worked for many years in this field. Why don't you tell us a little bit about your chapter and the issues that you raised? You were part of the stillbirths discussion, I think that was, but go ahead, tell us what's your big take home?
Okay, well, I'll tell you something about what we say in that chapter, and then maybe the big take home. So in the chapter, we're talking about not just stillbirths, but about death in general, and asking the question, what makes death bad for the person who dies, right? Which is very different philosophically to the question of what makes being sick bad for the person who's sick, right? You're there when you're sick, you experience it, bad things are happening. That's not true of death. One of the things that is distinctive of death is that you're not there when you're dead.
So true. You can tweet that.
As far as we know, as far as we assume. Right? So then the chapter is about what makes death bad for the decedent, and the idea there, which I think a lot of people accept, is it's bad because of what you miss out on as a result of dying, all the goods of life that you would have had that you don't have because of the death. And that's how we managed to quantify loss due to death in measures like QALYs and DALYs. So the sort of interesting and maybe novel part of this is a question that Zeke alluded to, which is about how age affects how bad it is to miss out on future life, right? So whether very young children, whether it's as bad for them to miss out on future life as it is for young adults, and going back to the stillbirths question, whether the loss of life for a stillbirth, the loss to that fetus that's died, should be counted in the same way as we would count the loss to a newborn, a 1-year-old, or whatever.
He tells what practical difference does that make when we do the cost-effectiveness analysis? Because it actually turns out to be quite important in terms of the kinds of interventions that are higher up the priority list versus lower.
Yeah, so I mean, if you take current practice, where you start counting death as bad at the point that a baby has been born, that means that you put a huge weight on saving young children from dying, because if you save them, then you gain all these extra years of life. You put no weight on preventing deaths that are intrapartum. You don't get anything for preventing stillbirths. Now, this seems sort of ethically odd, but it means that, for example, interventions such as treating syphilis in pregnant women, which both help the health of the women, but also have an enormous effect on reducing stillbirth, those are going to get much lower priority than interventions for fetuses that may be at a very similar stage of development are born. So we have a newborn baby, interventions for those babies. So it's going to really downplay things that are going to prevent stillbirth compared to interventions for newborns.
Okay, it's complicated. We'll come back to you.
Yeah.
Okay. Dean, you are the author, obviously, or the editor of several iterations now of the disease control priorities 2 and 3. How does that body of work relate to this book? How are you hoping to push this whole agenda along?
I think there are a couple of answers. One is that the principal way of thinking about things in the disease control priorities series is cost effectiveness. And as Ole said, that often, not always, often leads to major questions of fairness for disadvantaged groups. The cost effectiveness can lead to ignoring that. And so as we think about the line of work in DCP, going beyond cost effectiveness is one lesson that I've learned. The second lesson relates to a chapter that Ole and I wrote on measurement of inequality and in inequality in survival. And the lesson, the motivation, the lesson that I took from DCP and other work was that things that get measured get a lot more attention than things that don't get measured. Stillbirths don't get measured, they get less attention. There's a discussion now that's leading them into being measured. So we talk about in inequalities in survival, differences in how long people live, as opposed to the inequalities that associate low life expectancy with socioeconomic status or geography. So we're not talking about those kinds of inequalities, but just how different within a society are the lengths of life. And we propose a measure. There have been measures around before. We propose one that we think is a little bit better. But more important, I think, than proposing the measure, we point to a direction for routinely establishing, alongside life expectancy, a measure of how different countries are doing on inequality. And we have a comparison of Norway and the United States. At the same life expectancy, not surprisingly, Norway is more equal. That is, the survival curve is more compressed around the age of life expectancy. And that inequality everywhere declines as life expectancy goes up. So in some sense, the broad message of progress is not only are things getting better, but they're getting more equal in life expectancy in contrast to income, for example. So we have an agenda which we hope might get implemented, but I think it's a practical, completely doable agenda with the demographic information that we have from the UN for cross-country time series measurements of the relative inequality in survival of countries as well as length of life.
Mm-hmm. And how do you see this playing out at the country level? So Ole showed us an example of how it's this kind of thinking is being applied in a particular setting. I guess it's harder to do for those financial protection and equity pieces. But can you talk a little bit about some practical applications that you've seen that are working? Or and the issue of the stillbirth stuff, you're also making a judgment where life begins as well. That's a very complicated issue in the United States. How do the politics of this play out? Have you been witnessing this in the real world?
You want to speak to this, Dean?
I've had a little experience with it on the stillbirth issue.
Yeah.
I was interested in the question quite a long time ago, and I got strong pushback from professional colleagues, some very prominent people you would know, that I should not write about this because it would generate concerns about freedom of choice of women, and that it really does raise all those questions. If you push the beginning of life back 1, 2, 3, 5 months, then that's certainly ascribing to that, let's say, 7-month-old fetus, a set of rights that parts of the political spectrum are opposed to. It certainly changed, looking at it, changed my view of the rights of a person 7 months into gestation. So those political issues, I don't think are well addressed by putting them under the table. I think the kind of thing that Joe's been writing about, that a number of us have been interested in for a while, it brings it out. There are explicit trade-offs to be involved. And from my own case, it's quite possible. I think people can change their views as a result of that kind of analysis.
Can I say something about the more general point? So there are a number of cases where you might ask the question of whose values ought to be considered. Right? So I think one of the things that both Ole and Zeke mentioned is about equity weights, or how you take distribution into account. Right? So you might think there, well, there's a right answer to the question of how much we should care about inequality versus how much we should care about the amount of benefits, right? You might think we can analyze that and come to a correct answer to recommend to decision makers. You might think that's something about which people are always going to disagree, and what we need to do then is go to the people who are going to be affected by the decisions and ask them for the values that they have that will be input into the decision. And I think that's a general problem that is that becomes really salient at the country level when you're asking whose values are the ones that that should be counted for these sorts of decisions.
Who decides? Okay, so these, as you can see, there's a weighty set of issues, and it's, you know, there's not a technical solution, and people can agree to disagree, right, in terms of the perspective, and how there's a whole section on process and deliberation. So maybe, Carla, that you have worked on these issues and also sort of the ethical, judicial dimensions of decision-making in health. What's your reflection as you take a look at this body of work?
Well, I think it's incredibly useful, and taking into account my perspective and the landscape in Latin America, it's very useful to address some of the issues we deal with that are very peculiar. For example, with regard to judicialization and the right to health care. The right to health care, the human right to health, provides a moral imperative to move forward with universal access and universal coverage. But the part that doesn't get discussed sufficiently in my part of the world is the fact that the human right to health is subject of progressive realization. Progressive realization means that we're going to take one step and another step and another step. So if you think about the concept of progressive realization, you realize that the human right to health calls for priority setting. Which step are we going to take first? Which of these duties are we going to prioritize, given that we cannot stand here and end up there in a second? So the work that I've been doing with the countries, a lot of it with my colleague Alexandre Lemgruber, because very often our outlet is health technology assessment groups, is trying to integrate ethics in their decision-making processes, trying to help them do these decisions in a way that is ethical. But certainly, a main challenge that we encounter is the perception that we shouldn't be taking these steps in the first place. That it's the understanding, the misunderstanding that the human right to health involves everything that is available anywhere in the world now. That's not possible. And but unfortunately, because the progressive realization of the human right to health hasn't been fully explained, we see that courts are often invoked to make decisions about health, about what is provided. And those decisions are problematic for a number of reasons, including that they very easily can bankrupt health systems. You know, you make a decision in one case on an individual isolated case, and that has an impact for the entire system. It may be absolutely unsustainable. Then, you know, we were talking a moment ago about whose voices are heard. Well, those that have the money, the capacity, the already existing voice to go and sue. And so that means that we end up, if we rely on this path, we end up often continuing, perpetuating these inequalities that we try to address in the first place. So the work we've been doing with the country started in 2012 at the request actually of Chile, and started including ethics in the priority setting processes. But since the publication of the Making Fair Choices report, we've been working also in the inclusion of the 3 substantive principles that are in the book.
Okay. Can you reflect a little bit on what is it that regional organizations should do or international organizations versus what is the task of each country's own ministry and priority setting processes? Because as the Ethiopia example points out, that it is very data and evidence intensive. It's very important to have local data and evidence to be able to feed into these kinds of analyses. At the same time, it's not like you would expect every country to be developing models for every new medicine that they want to implement. But we've been slow, I guess, at sort of creating those global public goods that we could share amongst ourselves. Do you have some reflections on that?
Yeah, so the countries that we serve, our member states, give us money to get something in return, which is technical cooperation. They want, in a nutshell, help from us doing the hardest part of the work. The easy part they can do on their own. They usually don't need our help for that. And with regard to the work and priority setting, I would say perhaps it's 3 types of work that they request. They request work helping raise awareness, help not just the general population, but also within the health authorities, help understand the progressive realization that the human right to health requires, and that requires priority setting. Then they ask for work for help building capacity. It's very easy to say, oh, let's have a moral deliberation on whether we choose A or B. I'm telling you, when you start a moral deliberation exercise, about 1/3 of the people in the room will be so uncomfortable with having to face one of those terribly difficult decisions that they often will even ask if they can leave the room just to, to calm down a little bit. So it's a practical thing, and you need to learn. And they want PAHO's help to build local capacity. But then the third thing that we're requested to do goes exactly to your point before about, well, this is not a one-size-fits-all. Absolutely no. And we can talk about a number of different outlets, and the countries are very different. And they also want to figure out how exactly do we do this given what we have and the tools that we have, so they are aware of, we work on making them aware of all the global resources that are available, but they need to do their homework too. And so it's a long process.
It's a long process. So Peter, you lead the Tufts Cost Effectiveness and CEVR. You'll remind me exactly what every letter stands for. But you've been working both in the U.S. as well as overseas. You put together a clearinghouse of data and quality studies. How are you seeing these issues? What are those global public goods that you have started to use, and what kinds of insights have they been generating?
Right. Well, first of all, thanks for inviting me, and congratulations on the book. It's great to see it. So my background's in cost-effectiveness analysis. Our center runs a large database of cost per dollar averted and cost per quality gain studies. Published literature, we have thousands and thousands of these. Also relevant, and I'll mention, I recently was the co-chair of the U.S. panel on cost effectiveness as the update of the U.S. guidelines. And these experiences, I think, are instructive to today. The second panel, by the way, Oxford University Press 2017, if you don't have a copy.
We had an event here. It's good, very readable.
It's 500 pages on cost effectiveness analysis, one chapter on ethics. And the chapter talks about some of the ethical problems, some of the distributional consequences, but it's one chapter. So it's great to see a whole book dedicated to these issues, fairness and equity and distributional issues and so forth. The published literature, if you look at it, it tells us something about our opportunities to invest efficiently and produce the most health for the dollars we spend. But authors rarely talk about distributional consequences, sometimes in a hand-wavy way in the discussion section. The other interesting thing about the published literature is, and just take the global health side, it's largely, and the book talks about this, it's largely focused on infectious disease. Relatively few studies on non-communicable diseases, few studies on injuries and mental health and areas of real high burden, particularly in lower and middle income countries, but we're just not doing the cost effectiveness analyses. The other point that in the book makes it, a lot of the studies are focused on technology, drugs and immunizations, and those are important, diagnostics, those are important. Very few studies on care delivery, system type changes. Hard to study those, but certainly, and there are ethical implications to studying certain areas and not others. So I was really pleased to see the book, the focus on extended cost effectiveness analysis, which is a real innovation, the focus on institutions and public engagement. I think all of that is great. Dean has talked in the past about a dashboard, which may or may not involve dollars and qualities, and we can talk about that. But the idea that we need information beyond cost effectiveness analysis. Decision makers need multiple disaggregated and maybe aggregated information. And it's a false choice to say we need cost effectiveness or we need this. We probably need all of it, and I think it would help decision makers to have some parsimonious set of information, but multiple types of information.
Thank you. I want to ask all of you, so we've been talking about the sort of country-level decision-making resource allocation. What about international agencies and global health initiatives? Any reflections, maybe starting with Dean, on the relevance of this kind of thinking and how you would hope to see them taking on these kinds of insights?
Well, I think, to me, the starting point for that discussion is that while national governments should place great weight on intervention cost effectiveness in allocating resources, public sector resources, that's absolutely the wrong criterion for the international system. If something's high priority in terms of cost per death averted, then the country should pay for it itself. So what does that leave for the international system? Well, it either leaves very low priority interventions, so I'm not in favor of that either, but it leaves a set of international public goods, control of international adverse externalities, transfer of technology and best practice, leadership of the sort that WHO and other agencies show, and all those things cost a lot of money. And I think the vision that I would have as aid evolves over the next 10 or 15 years and as country incomes go up and the capacity for domestic resource mobilization rapidly grows, not to use that as an argument for diminishing development assistance, but for changing its direction.
I mean, you could argue that some of the global health funders have been financing the next most cost-effective intervention. If you think about something like HPV vaccine or even antiretroviral second line, third line, those are things that are not necessarily cost-effective and affordable for a low-income country. So, sort of practically speaking, they're doing the next most cost-effective. I don't know how you see that argument, but in general, it's an interesting point. They would have to fund totally differently from the way that they're funding today, though. I think we could agree, right?
Yeah, but I think there is something to that argument. I have some reactions to it, but
Yes.
maybe not here.
Okay, we'll do that in the reception afterwards. I think maybe we'll go to the audience. We have about 8 minutes left for our event. That's correct, right? Okay, so why don't we take a couple of comments or questions from the audience, and I also commend the book as well to all of you to read in detail. And then maybe a little add on some of the, we've been working on this at the Center for Global Development also since about 2011 when we hosted a working group with many of the people here today to look at how countries were running priority setting processes for their own domestic health spending. I think, one thing that still remains true today is that most countries have a very inertial process for deciding where monies go and how they are used, and it's driven by the installed capacity that they have at country level. And so The change to that, the reason why a lot of countries focus on specific medicines is because that's the spend they can see. So the question is, as those payment systems evolve, as they have in Latin America to some extent, will we see more of these deliberate resource allocation strategies where committees are formed, where evidence is demanded, where data is generated, and where there is this deliberative process, and then a decision on coverage and reimbursement in the way that we're imagining. Some countries are already living the dream, Thailand, Brazil, especially on medicine spend, Chile to some extent in the ALLOCATING program. There's lots of good examples, but I wouldn't say that it's taken off like wildfire yet, although obviously I am a passionate advocate for that to happen. Can you reflect a little bit before we go to the audience on how quickly will we see this change? We live here, we're sitting here in Washington, D.C., and we now have ICER, which is a non-governmental organization that CEVR works with a lot, that has been trying to do more positive cost-effectiveness analysis and advise insurers on coverage decisions. Maybe we'll start with you, Peter, on that.
Yeah, so
whether this whole thing.
ICER is the Institute for Clinical and Economic Review. It's a private, but somewhat like NICE in the UK, doing cost effectiveness, cost per qualities. Again, it's private, no regulatory reimbursement authority. But, and Zeke and I were just talking about this, it does show that progress is possible, that the US has been very reluctant to use cost effectiveness analysis, equating it with rationing and death and all that. We've seen progress. ICER is now routinely evaluating expensive new drugs and sometimes other technologies. And while it's not in the government, the private sector seems to be watching and listening and using that information to negotiate prices and manage drugs. You mentioned some examples globally. I was in Thailand, HITAP, and the folks in Thailand. It shows with leadership and time and effort, things can change. It's hard, but I think we can be optimistic.
We can be optimistic. Carla, do you have any
I
reflections?
am very optimistic by nature, but specifically in this topic, it's been very interesting to see this constant demand that we get from the countries to clarify, to help on ethics of priority setting. And it's been very interesting also to see how, for example, the Making Fair Choices report now has a life on its own. It used to be Carla presenting in here. I probably presented it 80 times. But now I get pictures from people at meetings like, oh, hey, yeah, it was presented. We found out with Ole, Alex Verhoeven actually discovered that the former Secretary of Health in Argentina had done a number of presentations of the full report in great detail. So it's very interesting to see that there's this thirst and that whatever is being received is being used. And of course, there's a lot of room for improvement, not only improving priority setting, but also improving the amount of money that goes to health in the first place. But I also see that we're getting the pushback from the countries. And pretty much the point you made a moment ago, after training the countries on ethics of priority setting, one of the Vice Minister of Health of one of our countries at PAHO's Directing Council said, hey, I learned about ethics in priority setting. Why don't we use this for the development of the strategic plan at PAHO?
Yoo-hoo! Okay.
So we're still getting it better.
Yeah. Great. Go ahead, Joe.
Just very briefly, which is to say that the US is actually a very unusual country, and I think we shouldn't.
We call it special.
Special, sorry, it's a special country. I come to somewhere that has a special relationship with it, so I should know that. And so I think we shouldn't be misled by the fact that we're in the US into thinking that its trajectory is the standard one, right? All high-income countries, as far as I know, have some form of universal health care. Many, many countries in the world are either there or are moving there. And over time, since they're going to have constrained resources and they're going to have to allocate them, setting priorities is going to be something that gets done in more and more countries.
Yeah, absolutely. So we obviously will learn from our European colleagues. Do you have any last thoughts on this? Okay, so we'll go to the audience. 2 or 3 comments quickly. Anyone? Maybe go ahead. Say who you are and where you're from.
Tiago, an advisor at the EDS 15 World Bank. So a question to you. You were talking about the philosophically question of why saving a life is good, and you think of the years of the person that she's not going to enjoy. Do you consider the benefits to others? Most goods and services only accrue to the person that's enjoying them, but life, I think, is something that people especially care about the lives of the ones that they love. And would that change anything on your...
Mental health benefits
Yeah.
to one's loved ones. Okay, let's take another comment, question over there.
Hi, I'm Brittany Charm from Zipline International. I'm curious how you think about the trade-off of cost effectiveness with UHC and thinking about hard-to-serve populations, the value of universal access and health equity, and how to think about that, particularly in some of the hardest-to-serve communities where there are low volumes of people, but there's some value. Intrinsic value somehow of reaching those versus, for example, a much more cost-effective hospital to be able to reach might be one that is just a couple kilometers down the road.
Thanks. Third, right there.
Hi, I'm Tara Bracken. I'm at the United Nations Foundation. I primarily work on malaria, and I was wondering, do you have thoughts on health priority setting when it comes to high burden versus elimination settings? Obviously there's lower cost effectiveness, but the intangibles are really high for some of these disease elimination programs. Do you have any thoughts on how governments can set priorities for those types of diseases?
Great. And I'll add a final question because we're in the midst of a coronavirus outbreak. How do these priority setting mechanisms have some utility in an outbreak situation? How do you decide? This is a classic example of a huge wave of urgent requirement. We'll throw anything at it. And what about the opportunity cost? How should governments think about this? So maybe we'll start with you, Joe, and to answer the three questions. So we had something about how do we value the benefits of our lives to the people around us, rural areas, elimination versus eradication kinds of questions.
All right,
Elimination versus
Let me say
control.
something briefly, at least about the first two questions, so as not to take up too much of people's time. So the question you ask, I think, is a really great one, and it speaks not just in the case of preventing death, but in other cases as well to the issue of what people call indirect benefits. Right, so the direct benefits of being treated for a disease are the benefits to the individual patient. The indirect benefits are the benefits to any third parties. So for example, the person who would be having to look after their sick child at home, the economy if someone can go back to work, and so on. One of the things that is argued in one of the chapters in the book is that we should be taking account of those indirect benefits insofar as we're able to measure them, and insofar as they're substantial enough that it's going to make a difference to take account of the indirect benefits, not just the direct benefits. Should I?
Do you have add to anything else, or?
I can add to the second question. I'm
Yeah,
just
yeah, go
concerned
ahead.
that we're going to run
That's okay.
out
We'll
of
do it
time
fast.
if we
We'll
all-
do it fast.
Okay. I think what you've described in terms of the hard-to-reach populations versus the easy-to-reach and therefore cost-effective populations is like just an example of a priority-setting question which is at the heart of the debates that we're having, right? There are populations that are hard to reach, say rural populations, who may be disadvantaged in multiple ways. And on those grounds, we would want to give priority, but for whom it's much more expensive to give a benefit. And on that grounds, they would normally get lower priority. And that trade-off is the trade-off between caring about equity or caring about inequality and caring about the magnitude of the benefits that we provide. I don't think any of us have a good answer to the correct way to manage that trade-off, merely that it should not be ignored and we should not simply be trying to maximize the benefits. We don't always treat the urban, easy-to-reach population because it's cheaper.
Okay. I think it's that same graphic that Zeke was referring to, the trade-off between financial protection or poverty cases averted and health gain. So we're always in a balancing act, and we're forgoing some good stuff on one measure to achieve something on the other. And getting that balance right is what that deliberative process is about. Dean?
One further thought on that question, which is I think the vocabulary we use is very prejudicial to movement toward greater equity. And what I mean by that is that we automatically assume that the cost effectiveness community will say averting more deaths with a given amount of money is more efficient. Now, they don't have to say that, but the DALI construct, the quality construct, all really have that baked in. But that is a misuse, in my personal view, and I think in a lot of standard economics, of the use of the word efficiency. What we have here are two quite separate objectives. We should be treating them as a multiple objective concern. One is to avert deaths in this indigenous community, and the other is to avert deaths in the mainland community, or whatever you're talking about. And efficiency comes from not leaving any money on the table. That you might put all of your money in the expensive way to avert deaths in the indigenous community, or all your money in the other. It doesn't avoid the hard trade-offs, but it makes them explicit, and it doesn't prejudice things by phrasing one approach as efficient and the other not. That just sets a groundwork against the equity position. So I might make one comment on the interesting question on malaria. Clearly, by the time you get into dealing with malaria in low prevalence communities, deaths are rare, the cost per death averted goes way, way up. What's the argument for spending money there? How do you talk to your finance minister or for aid budgets, excuse me, to spend money there? It's that there would be broad external benefits to moving toward eradication and cross-border benefits. So they're basically international goods, not national goods. I think your finance minister would be quite right to say, let's not spend money on that last 3%. But the aid agency probably should.
Mm-hmm. Yeah, that's a good answer. Okay, Carly.
Yeah, so I want to go back to your idea of balancing act. And I think we've been talking about what gets balanced, but perhaps we should add how that balancing is done. So what's the procedure? And I think it's essential to this balancing act to do it in a certain way with transparency, with publicity, and in a way that legitimizes the process, that anyone can see why this was chosen as opposed to this other thing. And that brings me back to your point about coronavirus. In a situation, in a public health emergency, where we have to ensure that the population continues trusting the health authority to continue to follow the best advice, it's essential to make sure that that decisions, important decisions about priority setting, that the criteria guiding the decisions are public, that there's this transparency, so people understand, oh, that's why this was decided. It was not just to exclude me, or there was a good reason for that. And that really feeds into the constant trust that we need the population to sustain, especially in an emergency.
Yeah, that's right.
Just a couple of points. On the hard-to-reach populations, I would point you to the book because it's very thoughtful on issues around equity versus magnitude of benefit, and I think, Joseph, you said that. On the virus, the discussion not far from here seems to be around 2.5 billion versus 4 billion versus 8 billion, at least as it's playing out, as I hear it, not very thoughtful about priority setting, like what you would do with each of these. So I would think there's a real need for people to be thoughtful about priority setting, whatever the number is. And not to mention the cost effectiveness of public health infrastructure, which we should have been having that debate all along and probably put a lot more money in years ago. But it also gets to some interesting methodological issues around, are we capturing well in a cost effectiveness analysis some of the issues around, for example, fear of contagion. If there's a vaccine, it'll be cost effective, perhaps it'll be, we'll measure that. But there's all kinds of sort of externalities, spillovers that we should be thinking about and often don't get captured.
And I mean, if you think back to H1N1 and the massive purchase and stockpiling of Tamiflu would be an example of, well, it shortened the duration of illness for a couple of days. Was it worth it? Yeah. Versus the other health that we forewent. I don't know if you would say it that way, but anyhow, I think we've come to the end of our time. Thank you so much to the authors and editors and the panelists and to you in the audience. Thanks.
Thanks, Amanda.